I just can't talk about that. Okay, so I'll start actually by taking this opportunity to express thanks to the university and the Friends organization and those in attendance. I am, as was mentioned, this is my second year on faculty at the university, and I consider myself privileged to have been given this perspective so early in my career. It's easy to come into the university on a day-to-day basis and engage in the teaching and engage in the research and engage in the clinical and community work that we try to engage in without understanding or maintaining the perspective of the larger organization and all the efforts that go into that organization. And so I wanted to specifically thank all those here for what goes on here that enables everything that goes on there. So what's going to go on here in the next 15 minutes? I'm going to take a moment to put myself in context for you. I don't come up through the typical academic trajectory. Then we're going to be introduced to the notion of autism spectrum disorder. I'll say that I'm going to use the term autism spectrum disorder and autism and ASD all synonymously. We're going to then zoom in and talk about autism in young children specifically. I will then do my best to make the case for earliest possible identification of autism in young children. And then talk about some of what we're trying to do to contribute in that regard, and end by speaking a little bit about the future of autism research at Hebrew University. So I did complete my doctorate up at Yeshiva University's Furkav Graduate School for Psychology in New York, which means that all of my clinical training took place in communities in the Bronx and Harlem. So having spent 5 years working with populations there, by the time I finished my doctorate, I was fairly determined to devote myself not to academia and not to research, but to community mental health, specifically community infant mental health, and working with underprivileged and underserved populations. I then had the privilege of completing my postdoctoral fellowship at the Yale Child Study Center, and what became clear to me in my time at Yale was this marked chasm that exists between what we'll call the community, so places like the Bronx and Harlem, and academia. So there's a very large gap between those doing research on things like child development, things like autism, and those families and children who are actually dealing with these issues on a day-to-day basis. And so my professional aspirations shifted a bit. Today I am very proud to call the Hebrew University my professional home. And it's there that I'm beginning to engage in some of the work intended to bridge between research and clinical practice. So what is autism? In the world of mental health, we have our own Bible. It's called the Diagnostic and Statistical Manual of Mental Disorders. The latest edition was published last year. And in it, if you want to understand autism, you open it up. And what it tells you is that to diagnose somebody with autism, you have to basically prove two things. The first is that this is an individual who has a very hard time socially, so deficits in social communication and interaction. Either they are not adept at engaging in the social world, in social interactions, or they don't even have a desire to engage in that social world. The second thing you have to prove is the presence of restricted and repetitive behaviors or interests. So either there is a behavior that these individuals engage in repetitively, or there's an area of interest that captures their attention to almost an obsessive degree. What's significant is that these aren't people who are just really interested in something, they're kind of history buffs, but this is a topic, either a behavior or an interest that captures their attention at the expense of their engagement in the social world. So we're here to talk about autism in young children. What is young? There are a couple of ages worth mentioning here. The average age at which parents initially express concern about their child's development with regard to autism is about 15 to 18 months. We'll say about a year and a half. So that's the point at which parents, not knowing anything about autism, not having any formal training in child development, are still seeing symptoms expressed enough to the degree that they are concerned. Their child is doing something atypical. Why aren't they like their siblings, their cousins, their peers? The other important average age, and I'm using averages because one of the hallmarks of autism is that it is a tremendously heterogeneous disorder. So what we say in the field is that if you've seen one child with autism, you've seen one child with autism. The average age of diagnosis is around 4, 5, 6 years old. So what we see here already is a significant issue being highlighted. The earliest signs of autism, even if a child grows up under a metaphorical microscope and we examine them very closely from the time they're 2-3 months old until they're bigger, the first time a trained clinician or a trained scientist would see signs of autism would be at about 12 months. Parents are first concerned at about 1.5 years, but then the average age of diagnosis is 4+. So that's a problem. Why is it a problem? Why is it important to diagnose early? What I'm about to present is basically the rationale for all early intervention work. The earlier we identify concern about a child's development, the earlier we can do something about it, the earlier we can treat, and the more right we have to be optimistic about altering that child's course of development. Now, again, while that's the basis for all early intervention work, it's actually a tremendously exciting statement to be able to make. Because what that statement means is that the core features of autism are malleable. We can change something here. It's not that we diagnose a child at 2, 3, or 4, and then we just watch them develop on the course that they would have developed on regardless. No, we diagnose them at 2, 3, or 4, and then we get in there and we do something about it. And we have the capacity to do something about it, to alter their developmental trajectory. To further illustrate this point, here are 2 fictional developmental trajectories of children. The top line, I'm colorblind, but my son told me it's yellow. So the top line represents a typical course of development. The lower line, I don't remember what color he told me it is, so I'm at a loss. The lower line represents a course of development for a child with autism. Now, it's important to point out that both children are growing and learning and progressing, but their rates of learning and progressing are very different from each other. What's important for me here is the point at the very beginning. At some point, these 2 children are developmentally very similar. So even a very well-trained professional, if they look at 2 6-month-old babies with their naked eye, they're largely unable to distinguish between a child who's going to go on and develop autism and a child who's not. But something is happening there. Something is happening in the first 2 years of life that is causing a really significant wedge between these 2 developmental courses that's causing really significant differences at the end and causing them to develop in 2 very different directions. We have some theoretical notion of what that thing is. Autism is not a cognitive disability. It's not an intellectual disability. We know that many children, many individuals with autism are intellectually disabled, but many are not, and many are very bright. Autism is not a language disability. It is a social communication disorder, but many individuals with autism have completely appropriate language capacity. What autism is, at its core, is a social disability. And that's important because how do we learn when we're babies? We learn because we view the world through a social lens, right? So how do we know that an apple is an apple? We know because mom or dad holds up this shiny red object in their hand, looks at us, looks back at the object, and says, apple. And we know that although they're not looking at the apple right now, we know that they want our attention. They want our attention not only on them, but also on this object. And this sound, this random group of syllables, is being directed towards us, but actually refers to this thing. And so we learn that apple refers to this shiny red object. But if we don't view the world through a social lens, then we don't learn that. And so impairment in social functioning negatively impacts our ability to learn in general. And obviously, impaired development in other domains is going to come back and cyclically impede our social development. Now, we want to obviously catch this early, because if we don't catch it early, what we're left with is much more significant differences later on. And not that we can't treat adolescents and young adults with autism, but we're then talking about mitigating symptoms and not significantly altering their trajectory. It's important to point out that it's not that if we catch a child young, we can make them not have autism. That's almost never the case. But what we can do with good intervention is get their trajectory to more closely resemble the trajectory of a typically developing child. And so for me, this little circle on the bottom represents an ethical imperative for us. It means that if we have this capacity, and we do, we have the knowledge, we have the ability to identify it early, and to some degree we have the ability to intervene, it means that these are the kids that must, on a moral level, be identified and intervened with. So I hope that I've made the point that it's important, it's something that we want to do. The question is, of course, do we? And the answer, unfortunately, is not really. So we've said the earliest signs of autism would pop up at about 12 months, 18 months. We've said parents are concerned at about 1.5 years. There's a notion of diagnostic stability. So diagnosing autism is no simple feat. And it typically is a multidisciplinary evaluation process that demands high levels of expertise and training. But by the time a child is tested at 2 years old for autism, if it's done properly, we think that that diagnosis is stable, which means that when that child comes back at 3, 4, 7 years old, they're going to probably maintain that diagnosis. So we know how to diagnose autism at 2 years old in most cases, and yet, as mentioned, we have the average age of diagnosis far above that. On top of that, we'll throw on all these risk factors that exist, and here are just a few examples, but if a child lives in a rural area, that average age of diagnosis is going to go up. If that child is poor, the age is going to go up. If the child doesn't have a consistent primary care provider, same story. That age is going to go up. So we've said that we want to identify early so that we can treat, so that we can help. We have said that it's a time-sensitive issue. We've also said that while we have all this knowledge, that's not what's happening in the field. So the question is, what do we do? What can we possibly do about this? Conveniently, this segues nicely into a number of the research projects that I'm currently involved in. So my research currently takes 3 distinct but interrelated directions within the field of autism and other developmental disabilities. The first of which I'll talk about for a moment, the second and third of which I won't go into detail, but I'd certainly be happy to have that conversation on a personal level after this. So we're looking at babies, community, and families. As regards babies, we're developing, and I'll talk about this in a moment, a screener for the early identification of autism, something that exists, but we're looking at a novel way to engage in screening in the community. That obviously overlaps with the community aspect of the research, but we're also specifically looking at lower socioeconomic areas, and specifically we're working actually with the Israel Fund for UNICEF, looking at discrepancies between East and West Jerusalem and how to maybe rectify those discrepancies. On a family level, this is actually the avenue of my research that does not directly stem from what I've said until now, but we're looking at the notion of family mental health when there is a child with special needs, and specifically the effects of respite care, or giving these parents a break, an opportunity to anywhere from go out for a cup of coffee, which is something that is luxurious to them, to something completely crazy like going away for a weekend, and how that impacts the family's ability to function both in the short term and in the long term. But I'll take the next minute to talk about our work with babies. So this is a project that's taking place in collaboration with colleagues at Yale and within Hebrew University, and in cooperation with the Ministry of Health in Israel. The child development system in Israel right now doesn't have a formal system for screening for autism. So the nurses who engage in the well baby visits are trained on autism and are trained very well on early childhood development, but there's no standardized empirically based screening tool used to screen for autism at young ages. So we want to incorporate that. That's pretty basic. What we'd like to do is include into that screening process an innovative technology-based screener that I'll go into in one moment. And the last thing we're trying to do is develop an intervention that we're thinking of as intermediate intervention. So in addition to the gap in time that I've highlighted already, we also know that kids can wait about 6 months from the time that they're referred for a diagnostic evaluation till the time that they're actually seen. So now we already know that there's concern about this child, but we're still not beginning services for maybe another half year. So we're developing an intermediate intervention process by which parents would take part in groups that would be psychoeducational. So instead of sitting at home doing nothing and just waiting to be seen, they're already going to be learning about maybe some modifications they can engage in with their children at home, in school, that might target some of the behaviors that highlighted the concern to begin with. In terms of the technology-based screener, and it's really a 30-second version of a 2-hour talk, but there's a lot of research on the early development of autism that comes from the eye tracking world. So basically you sit a kid in front of a screen and you show them something on the screen, and we can track with excellent precision where exactly on that screen they're looking at any given moment. And we know that young babies who go on to develop autism have very different looking patterns than babies who do not go on to develop autism. So the obvious one is that they're less attracted to social stimuli on the screen. So this movie, which we don't have to play right now, a typically developing child or a child who goes on to not have a diagnosis of autism is more likely to look at this woman's face. She makes a sandwich at some point. They look at the sandwich when she looks there. If she looks at the monkey, they look at the monkey. A child with autism is not going to do that. A child who's going to go on to get a diagnosis of autism is going to be less likely to look at the screen. If they do look at the screen, less likely to look at her. And if they look at her, less likely to look at her face. And there's even finer resolution than that. Eye tracking technology costs about $30,000 to $40,000 for a machine. We're working with tech companies in Jerusalem and in Norway who have developed eye tracking technology for iPads, for mobile technology. So we can now take any iPad and turn it into an eye tracker. So our idea is to take what we know already about eye tracking patterns, put it on an iPad, incorporate it into an empirically supported screener to get additional information so that we'll be able to calculate a more specific risk score for children when screening for autism to determine whether or not they should be referred for an evaluation. Well, there she is, but you get the idea. Okay, so I'm going to take my last minute to talk to you about something that I'm probably the most excited, actually, to talk to you about today. I'll say unambiguously, this is a project that does not formally exist right now, but it is going through the avenues and through the processes. It's a joint project between the School of Education at the university, the School of Social Work, pediatrics at Hadassah Medical Center, and the Faculty of Medicine at the university. We are in the stages of developing a center for translational autism research. That will be a collaboration between the university and the hospital. I'll just point out that our wonderful partner at Hadassah is the chair of pediatrics, Professor Eitan Karam, who happens to be married to Professor Batya Karam, who is sitting here. This was really a coincidence, but worked out nicely. The goals of the center are going to be threefold. The first is obviously engagement in both basic research, but with a focus on translational research. So research that has clinical utility. The second is the provision of clinical services, both through research avenues and to the broader population. As part of that, we'll be engaging in training for autism-related professionals coming up through the university and the hospital systems. And the third direction is community outreach. So working both with practitioners, but also importantly families and children who are out there currently dealing with autism and developmental disabilities. One of the things we'll be doing there is something called knowledge translation. So how do we take what we know in the world of academia and research and translate it into a meaningful avenue to communicate to people dealing with these issues on a day-to-day basis. So again, this does not exist, but we are moving in that direction. And my hope is that by the time you're sitting here next year, it will be something that exists actually in reality, not just on this slide. But in the meantime, I will thank you for your attention.